Lucky Land Slots, you can get lucky just about anywhere.
Dearly beloved, we are gathered here today to... Has anyone seen the bride and groom?
Sorry, we're here. We were getting lucky in the limo and we lost track of time.
No, Lucky Land Casino, with cash prizes that add up quicker than a guest registry.
In that case, I pronounce you lucky.
Play for free at LuckyLandSlots.com. Daily bonuses are waiting. No purchase necessary. Void where prohibited by law. 18+. Terms and conditions apply. See website for details.
Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen, and I thank you so much for listening today. If you enjoyed the podcast, of course, go to reallifepharmacology.com. You can sign up there and also snag a free 31-page PDF study guide on the top 200 drugs. So go snag that for free, and we'll also get you email updates when we've got new releases of the podcast and other content as well. So definitely a no-brainer to go grab that resource for free there. So today I'm going to cover Sertraline. Brand name of this medication is Zoloft, and I've done a couple of SSRIs, I believe, so far, and with that, there's subtleties between the SSRIs, and I wanted to make sure that those are all pointed out because they are important, and there is different reasons for selecting different SSRIs or different things to look out for as we use these medications. So mechanistically, it's not going to be different from any of the SSRIs if you've listened to previous podcasts on drugs like citalopram. So those presynaptic cells or neuronal cells release that serotonin, and they will also reuptake, basically take back in that serotonin out of the synapse and essentially stop that serotonergic activity. SSRIs block or reduce the amount of that reuptake that happens. So more serotonin stays in the synapse and gives you physiological responses and hopefully helps manage, treat indications like depression, anxiety disorders, PTSD, OCD, in the way the medication works there. All right, so one thing I really wanted to point out was dosing. It's just common sense. The higher the dose we start with, the more aggressive we get, the more likely we're going to run into adverse effects. So usual starting dosing range is 25 to 50 milligrams. In clinical practice, most often I've seen the 25 milligram starting dose utilized. In geriatrics specifically, I have actually seen 12.5 milligrams started as well. So what you're going to look at is, severity of depression, how aggressively do we want to get after this, potential, tolerability issues in the past, maybe with other SSRIs that have been tried or other antidepressant medications, possibly genetic variants may be looked at as well if genetic testing has been done. It isn't typically done, at least at this point, for patients that maybe have never tried an SSRI, but I think it is going to get more common as we go on there, certainly. All right, so thinking about that dosing, we need to think about adverse effects. So if we get aggressive with the dosing, the side effect you're most likely to see, or at least the one I've seen most often in clinical practice, is nausea and maybe more specifically diarrhea. So sertraline has been nicknamed Squirtraline because it definitely causes diarrhea more frequently than some of the other SSRIs. So that is definitely one big differentiating factor with sertraline compared to some of those other agents within the class there. Nausea I mentioned as well. It's important to note that patients may become tolerant. They may kind of get through the initial period, and it may be okay for them to continue that. Obviously, you're going to have to look at that patient clinically. How severe is the nausea? How severe is the diarrhea? And what are we going to do about it? Do we just back off on the dose for a period of time? So maybe you started at 50 milligrams and they're having problems. Can we just back off on that dose? If you started at a low dose, maybe we can go to every other day for a period of time and then, ramp it back up again, and it might be okay that way. So you're going to have to work with patients there. Obviously, we can switch potentially to another SSRI as well that may have a lower incidence of those GI adverse effects. So important to think about that, work with patients clinically, assess if they have had any benefit, which I'll talk about in a little bit here as far as how long that generally takes. But yeah, important to work with patients on that and assess the severity of symptoms versus the risk of continuing there. Of course, all SSRIs have that box warning on suicidality risk, suicidal thoughts. Important to remember that, monitor patients closely, certainly as we're starting and increasing doses. CNS changes can happen, fatigue, insomnia, dizziness, dry mouth. I would say it's not incredibly common. And as far as, you think about fatigue versus insomnia, I have seen both happen. So definitely, just pay attention to what the patient's reporting, and checking in on them and monitoring them is certainly important. Sexual dysfunction, significant problem with SSRIs in general. Sertraline is no different there. So that's something that's sometimes forgotten about and not asked about by healthcare professionals. And it might be something that patients may be sensitive about reporting as well. So keep that in mind. Important to ask and assess for that as well. Serotonin syndrome, I'll talk a little bit more about that with drug interactions and some medications that may add to that. Tremor I have seen on occasion. I would say it's not real common. And again, for most of these adverse effects, it's going to be dose dependent. So as you get up to 150 milligrams, 200 milligrams, those adverse effects, those unique adverse effects, may come more into play. QTC prolongation risk, it's not crazy high on my radar. It has been reported in the literature. Certainly, citalopram is probably going to have much higher risk as far as the SSRIs go in relation to QT prolongation compared to something like sertraline. Weight gain is possible. Sertraline, again, kind of middle of the road there as far as the likelihood of causing it. Paroxetine I would generally consider on the high end. Fluoxetine would be on the low end of that weight gain problem. And sertraline lies probably somewhere in the middle there. Kinetics, sertraline does have probably a shorter to moderate half-life, about a day or 24 or 26 hours, I think is reported in the literature there. So what this means is, at least what I think about is patients who miss a few doses may have a higher likelihood of having discontinuation syndrome symptoms. And I believe I covered that on a previous podcast. But again, the shorter the half-life, the more likely, if we miss a few doses, that we're going to experience that discontinuation syndrome. So sertraline, I believe, is kind of in the middle of the road as far as that half-life goes. Fluoxetine is up on the high end there, where it's got a long half-life of several days, maybe even up to a week in patients who are chronically on that medication. With onset of action, very, very important to remind patients that antidepressants take a while to work, and sertraline is no different there. We've got to anticipate that we're probably going to be weeks before we get some sort of benefit going with that medication. That's a big downside because we may experience adverse effects immediately within the first few days of starting that medication. So it can be a challenge to navigate that, but it's important to remind patients of that it's not an immediate cure-all fix for depression. All right, so let's take a quick break from our sponsor, and then we will finish up with drug interactions. If you're in the market for pharmacist board certification study material like BCPS, BCGP, BCMTMS, or the BCACP exam, definitely go check out meded101.com/store. If you're a pharmacy student, we have NAPLEX study materials available as well, and you can find links there at meded101.com/store as well. If you're a healthcare professional looking for good information surrounding medications, whether it be drug interactions, clinical case studies, I've got a lot of Amazon books and Audible books as well. And Audible still has their offer available where you can go get your first Audible book for free. So I've got a 10-hour book on drug interactions. You can get that absolutely for free if you've never listened to a book on Audible. And again, all those links at meded101.com/store. All right, so finishing up on drug interactions. In general, I would say sertraline's probably got less potential for drug interactions through the CYP pathways compared to other agents like fluoxetine or paroxetine. So that's a good thing, certainly. As far as drug interactions go, I most often think about serotonin syndrome, of course. So linezolid, other SSRIs, SNRIs, cyclobenzaprine, tramadol, MAOIs, TCAs, triptans. All these medications potentially have additive serotonin type effects. So serotonin syndrome, while extremely rare, is extremely serious. So as we add more agents that have serotonergic activity, that risk can go up there. Bleed risk is a little bit more of a controversial one. Indeed, patients on anticoagulants, antiplatelet medications may be at higher risk for having additive bleeding type effects. And if you remember mechanistically, serotonin reuptake into platelets is a step in platelet activation. So if we block that, we, in theory, could potentially block platelet aggregation, which could increase the risk of bleeding. Again, probably not something that's real high on my radar in a patient on sertraline 25 milligrams and they're taking baby aspirin. But, patients on higher doses, maybe on, more and more blood thinners, you've got that patient that's on aspirin, Plavix, and an anticoagulant, for example. It might be something more significant to think about there, particularly if we're seeing anemia, bleeding, bruising. It may certainly be something to think about and monitor there, weighing that risk of, their depression, their anxiety coming back if we, reduce doses or change agents or something like that. So really a clinical judgment thing in that situation. But again, not crazy high on my priority list as long as the patient's not bleeding and we don't have, many issues with bruising or anemia, low hemoglobin, and that type of thing. Alcohol I did want to mention because that often gets asked with regards to antidepressants in general. There's potential that, CNS changes, like confusion and things like that could be worsened when using antidepressants like SSRIs in combination with alcohol. So in general, we don't encourage binge drinking, for example, but certainly the more alcohol you take, the more likely we're probably going to have, central nervous system impairment and that type of thing when these drugs are used together. So that really needs to be looked at kind of on a case-by-case basis, and certainly making patients aware that it could potentially exacerbate the effects from alcohol when we're taking an SSRI with that. QTC prolongation risk, I wanted to mention, it has been reported. I don't worry about it quite as much with sertraline as I do with a drug like citalopram, but you will see case reports out there, and oftentimes it's patients with other risk factors for QT prolongation. So I think that's going to wrap it up for today. And thank you so much for listening. If you enjoy the podcast, leave a rating and review on iTunes or wherever you're listening. That's greatly appreciated. Also, check out reallifepharmacology.com. Go snag that free 31-page PDF on the top 200 drugs. Great little study resource for you if you're going through pharmacology classes or if you just want a refresher once you get out into clinical practice. So go check that out. You can track me down, mededucation101@gmail.com, or LinkedIn is probably the best way to track me down there as well. So Eric Christensen, PharmD, BCGP, BCPS. All right, I'm going to sign off for today. Thanks so much for listening, and I hope you have a great rest of your day.
It is Ryan here, and I have a question for you. What do you do when you win? Like, are you a fist pumper, a woohooer, a hand clapper, a high fiver? I kind of like the high five, but if you want to hone in on those winning moves, check out Chumba Casino. At ChumbaCasino.com, choose from hundreds of social casino-style games for your chance to redeem serious cash prizes. There are new game releases weekly, plus free daily bonuses, so don't wait. Start having the most fun ever at ChumbaCasino.com.
No purchase necessary. VGW Group. Void where prohibited by law. See terms and conditions. 18+.